that people would be just kind of mingling around and not watching, but delaying time doing CPR. So I think in a real life situation, somebody would have actually started CPR, but it's important to see and watch back how this actually went. Good compressions, effective compressions, number one thing to do to bring that patient back, hopefully a functioning patient and preserving his brain, right? After that, airway. We have 60 to 80% of oxygen left in our system after it's gone through the body, body's picked it up, comes back to the right side of the heart. 60 to 80% oxygen left. Airway is not the most important thing. Luckily you're in here and you got people who take care of that. Compressions, and then if the patient's in a shockable rhythm, defibrillating as soon as possible. You get those pads on, you hook it up, you press start, and if it's a shockable rhythm, you charge and you shock. Getting that patient out of that shockable rhythm, along with compressions, is how we're going to save this person. Okay? So I want some people to comment. Y'all watched it. What were some of the good things? We kind of talked about some of the good and some of the activities already during it. What were some of the good things that you saw?
I like the fact that we did have an engaged anesthesia care provider.
Good.
Clear direction.
And that comes from being a good leader, somebody who's leading. And because I know, and I've done this before in here, you rely on the anesthesiologist to be that leader, or the CRNA, who's ever in here being the provider, because it doesn't happen a lot in here. So we need a good leader. What else?
Big delay, obviously, we discussed, but the long delay in starting CPR shouldn't happen.
We're talking about good things.
Oh. Everybody participated, everybody was willing to step in.
We had enough resources, we have enough people.
Yeah.
I think compressions were really good by your team. I think they performed effectively. I just like to have that tone out loud, because then when somebody gets tired, you get tired when you're doing CPR. So you need that next backup person. So you can say, I'm getting tired. You can say switch 2, 3, 4, 5, and then you're right up there ready to go. You don't want to have legs in CPR.
Anybody else have anything else good they saw? Besides the patient lived and y'all did good.
When the art line stuff wasn't in the cart, someone said, this is where to find it, this is who's going to go get it. Somebody was directed to, okay,
Good. Knowing where your resources and where your supplies are. Anything else? All right, how about some opportunities? We already talked about the significant lag time with CPR being initiated, and then in the middle, right there, nobody was right there to get right back on CPR, and it felt like a minute before somebody started again. It was probably 15 seconds, but it felt way longer than that. We should not be off the chest any more than 10 seconds for any given time. To switch out, to check a pulse, to intubate, anything. No more than 10 seconds.
Marla, I have a question. How important is it to have a backboard? There's very little padding, but that is a question that I was asked.
That's a good question. What I've always received during this is in procedural areas, the cart is pretty firm. They don't usually use backboard. In your experience, yeah. Regular beds, we'd always have a backboard, and we get that backboard underneath immediately. If you're ever in a patient that has a bed in here, I don't know if that ever happens, but the backboard is very important because we're not doing effective communications.
I'll tell you what, the backboard is a little bit overrated too. There was a code in room 15 a few years ago in a thoracotomy in the left lateral position, and I was doing CPR through the chest. I was on my knees and doing CPR AP, chest and back like this, and patient lived and went to cath lab and went home. But so, as long as you have effective compression, you will be able to compress the chest.
What else do we do if the patient has a device? How do we put the pads on if the patient has a device?
Good question.
You don't cover. You should not be covering like your ICD or your pacemaker.
So where do we put the pads?
In the back.
AP, right? Left side of the chest, front, and then turn the patient and put them on the back. You never cover a device. Good. What if the patient had a ton of hair on his chest And we need good conduction through those pads. What do we do if they have a lot of hair on their chest? We don't have time to shave the patient.
Put it on and rip it off.
Yep, put it on, rip it off, get another set, and put it on. An instant spot A.
Yeah.
How many people should be in the room about, because it seems like we always have way too many.
Always, every code. You have your code team.
Right.
So you should have your leader, your airway person, your respiratory therapist, at least 2 compressors,
All right.
somebody who's running the cart. It could be one person knows where the meds are, handing the meds, somebody giving the meds. We're not wasting time, I'm gonna grab them and then go give them. Somebody should be giving the meds, somebody should be at the cart, running the defibrillator, running the meds, getting the supplies out. There should be a designated person for the crash cart, especially if the patient's in isolation. We don't want somebody who's touching the patient, coming over here, touching everything, and then going back. So designated person for the cart.
So like 6 to 8 people.
Our code team, that's what they consist of.
Okay.
Yep, absolutely. There shouldn't be 5 doctors in the room. You know, if there's the 2 of them, you may want another physician in here. We call the code overhead now, which we're supposed to be doing. A hospitalist is probably gonna come. Should be 1 other physician tops. Theoretically, 1 physician should be able to run the whole code.
And then one person documenting, right?
And then the documenter, yes, I'm sorry. Yep. And he talked about that, the good communication. Everybody has to be quiet. Again, it's a chaotic, but it shouldn't be a noisy chaos. Everybody has their role. Who's ever recording, you heard him ask, when was the last time we gave medication? When we did this? If she can't hear what's going on, what's being given, something's gonna be missed. She shouldn't be doing like, what was going on? I don't even know, because I can't even see. You got 70 people in the room, she can't see, can't hear. Good communication is so key to know what everybody is doing so we can get a better outcome for this patient. No side talk. Any other questions or concerns? Go ahead.
So what is our process for codes, communicating codes in the OR 24/7?
If we have a code, we call 555 and announce. And then our team will arrive. Some of them will be able to come in the room, some of them will remain in the hallway. So
Okay.
that's what, back to how many people. If you see too many people, you can just politely ask if you can just step off and just wait outside. And if you see that people are tired, then you have to ask to bring somebody else for compression.
The other thing is respiratory is supposed, when they come, they're supposed to bring the Lucas to every code.
Yes, only.
If it's possible, if the patient's body habitus is such, we put the Lucas on, that has at least 1 or 2 people that do not have to be in the room, because the Lucas doesn't get tired.
Let them know what the Lucas is.
Oh, so the Lucas is the external compressor. I was hoping respiratory is gonna come and bring it. They bring it to every code. It has like a little curved backboard. They put it underneath the patient. It's got a big dome. It connects, it's good the arms are like this, because it actually has to connect to the backboard right here. It has a little a little thing that comes down, you press it on, and it goes rate of 100, 2 inches, every single time. It doesn't get tired, it doesn't stop, it doesn't have to switch out, because when we're switching out, you get that momentum going, and then we have to switch out or somebody gets tired, and we keep doing this. Compressions are constant. Now, every 2 minutes you check, you do a pause, and check to see what the underlying rhythm is. Still shockable rhythm or asystole, then you turn it back on and compress. You can defibrillate with the Lucas going. So you don't stop the Lucas to defibrillate. You can put the pads on around it. Patient's in a shockable rhythm. We're still compressing, charge it, shock it, and it keeps on going.
Okay. So we have 1 crash cart right now. What's the status on our second one? We're getting a second crash cart up here. Okay, so we have a second one coming up, and then we're also going to be ordering the Lucas to be on each crash cart for up here. Okay, so we're working on those to put those in process, but we'll add a crash cart, we'll add Lucas to it, we'll put some training on.
There will have to be training for Lucas.
For the Lucas, okay? But Olga is absolutely right. 24/7, you call a code, you get rid of the people you don't need on the code, okay? And then the other part of that is, and I just need some better signage, we have a rapid response team dress-up cart right outside of the OR. It's that gray cart that you used to do your temperature monitoring on, and below there it has the extra bunny suits. It's still supposed to have maps of the OR so they can grab those and come back. Put a bunny suit on, see the map, it's called in a particular OR, and then they come back to the OR to respond. So we may need to make sure we keep those stocked with the bunny suits and extra headwear and everything else so that they can come back, okay? So that's what that card is for, and we want to maintain that so that, and that's been briefed to, on the code committee and to the RRT teams, the response teams, to bunny suit up and come back.
So if it's a day shift, we should be, you want us to be pushing the code blue button so that goes off at the desk and the circulator can go right over and start compressing. So instead of calling the 555, like we should be pushing the code blue button when there's someone at the desk so they can start compressions, and then the charge nurse at the desk, they're having a code in room 10. Then they'll call the 555.
More than likely, what's going to happen if you get a code pushed at the front desk, or you hear it at the front desk, what's going to happen?
You wonder if it's real or not. Sometimes it gets hit accidentally.
You call,
When you call
or you go
Jared.
back, and calling doesn't
Jared.
help. Calling doesn't really help.
No.
Okay, so you go back and you check. Okay, and then you can call it overhead or just hit the code button. That code button is only for internal. Okay, it doesn't go out to the rest of the hospital and notify the rest of the hospital. So it's key to notify, because you then get the resources you need, somebody to get that crash cart and so on and so forth. So if that button goes off, the team leader or whoever is nearby supporting that room needs to go investigate.
And I'll tell you, now that I'm correct, that we're calling it overhead, the code team comes. The members of the code team throughout the hospital, both ICU charge nurses come. They're the ones that are in charge of the crash cart, giving the medications, putting an IO in if we need one, assisting with a central line if we need one. They're kind of the second lead for that. Respiratory therapy will come, usually 2 or 3 of those people. Nursing supervisor will be here as well. She's in charge of crowd control and making sure things are running smoothly outside. And then you have your lead and then the recorder. That's the code team out there.
I'm gonna put something forward. You can do it or you don't do it. You see these lanyards we have here?
Yes.
Last place I was, that was part of how we set it up, and that's why I was saying that's how we ran the codes, is the IV pole on there. You stick those lanyards on there as they respond, come and grab that. I'm a compressor, I'm a this, that, and the other, and you look around, you're not worried about the badge trying to see that, is you know that this is my next compressor or who my recorder is. I just recommend that.
Yeah.
You don't have to do it, you can do it.
It does cut down on the chaos of who's doing what. Everybody has a role. If you don't have a role, and I said if you don't have a role, you should not be in the room. Anything else? Sheila or Teresa's? Or Doctor?
Those are some good questions. Now's the time to ask them. And so how did the people who actually did it feel? How'd you feel compressing? Okay. Yeah, how'd you feel about the crash cart and doing the meds? Okay.
Makes me a little bit better when it,
Is real?
yeah.
Okay, so practice, we got a practice cart. Olga, fantastic job. She looks like she's got experience doing this. And when you're at night, you don't want to feel alone. You want to feel pretty confident in your team, all of your team. Anesthesia, the surgeons, the techs, they're a part of this. So we're going to have this posted on HealthStream for review and feedback as well. So take a look. We're recording this debriefing portion of it as well. Thank you so much.
Okay.
Thank you.
Thank you, everybody.